Morning, Catherine.
Hi.
I'm Emily. I'm the resident. I spoke with you yesterday.
That's right.
I brought the whole team with me today. You met Sana, our medical student, already.
Hi.
This is Dr. Van Opstel.
Hi.
She's
Nice to meet you.
the supervising physician.
I'm Mary Kate. I'm the nurse.
Hi.
Nice to meet you. My hands are sweating.
All right, so if it's all right with you, what we're going to do is Sana here is going to present, talk about Hannah to the rest of the team.
Okay.
Feel free to interrupt at any time if you have questions or you want to add something or we get something wrong, okay? Just let us know. All right?
Thanks.
It's all you.
Okay. So Hannah, she's an 8-year-old female with a significant past medical history of eczema, and she presents with abdominal pain. The abdominal pain started 5 days ago. It's been constant and progressive, and the pain is worse with micturition. Yeah, so, sorry, micturition is just another word for peeing or urination.
Oh.
Yeah, same thing.
Okay. Got it. Sorry.
Yeah, thanks for asking. And the pain is also worse with activity, and it's better with rest. The pain is quote-unquote really bad, but she's unable to describe it as either sharp or dull or anything like that. The pain was first all over and near the belly button, and then it became more so in the right lower quadrant of her abdomen. It's associated with 2 days of nausea, vomiting, fever with a Tmax of 103, and diarrhea with fecal incontinence. And that just means she's having accidents with her stool. Okay. The diarrhea they describe is more so just her not being able to hold it, but it's not voluminous and it's not very frequent. She's going approximately 6 to 7 times in the last 24 hours. There's no blood associated with it, and she has no sick contacts at home, and no recent travel out of Chicago. And of note, Hannah presented to the ED 2 days ago for the same abdominal pain on June 1st. The UA was positive for a UTI. She was sent home on Bactrim, and since then the urine culture has grown pan-susceptible E. coli. And per Catherine, no UTIs in the past, but she has noticed some smelly urine with her PCP, which they determined to be related to dehydration. Since then, she was sent home from the ED, and parents have been trying to give her the levofloxacin, but she was unable to tolerate it due to the vomiting. And Dad tried to give her small amounts of the antibiotics throughout the day, but she was still unable to tolerate it. Yesterday, she was able to keep down crackers and fluids, and she's reporting that she does feel a little bit hungry today. And Hannah's mother is concerned about the development of a new fever, vomiting, and fecal incontinence that brought her to the ED for further evaluation. So in the ED, she was febrile to 102, tachycardic to 120, and received IVF, Motrin, and ceftriaxone in the ED before being transferred to the floor in stable condition.
Okay. That was great, Sana. Thanks. That was a really good summary. Just one thing to clarify. Mom, just to confirm, she was on Bactrim. Is that right? Okay, so not the levofloxacin.
Okay.
Yeah, I heard both. Okay.
Great.
Thanks.
Thank you. Go.
Okay, yeah. So review of systems for constitutional is positive for fever and general malaise, and for GI as per the HPI, and the remainder are negative. For her birth history, she was born at 40 gestational weeks, C-section, and there were no complications prior to the mother, and no past medical history besides the eczema, which was diagnosed in 2011, no past surgical history. Medications, she's on the Bactrim 40 to 8 milligrams per milliliter, and she takes 18.45 milliliters by mouth Q12 for 7 days. And she has the hydrocortisone cream. She applies that twice daily and for 1 week. And no known allergies, and vaccinations are up to date. For family history, there's no history of IBD or other GI history. And she currently lives with both her mother and father, who share custody. She has one 4-year-old sibling who is healthy, and no smokers in the family. And she's developing well, normal growth, does not report problems with school performance, and no history of developmental delay either. So on exam, her vitals, she is febrile, T of 102.1, pulse of 110, blood pressure 85/50, respiration of 20, and SpO2 98% on room air. On exam, she's alert, active, cooperative, but she does appear a little uncomfortable, a little apprehensive. Her sclera are clear, pupils equal and reactive, extraocular muscles intact, dry mucous membranes, and no tears when crying. For the respiratory exam, there was no increased work of breathing, and breath sounds were clear auscultation bilaterally, no crackles or wheezing, and there's good air exchange. regular rate and rhythm, normal S1, S2, no murmurs, and 2+ pulses throughout, and capillary refill less than 3 seconds. So for the abdominal exam, it was diffusely tender to palpation, the maximal tenderness in the suprapubic region, as well as the right lower quadrant. And there was some guarding of McBurney's point, positive rebound tenderness and positive psoas sign, but negative Rossings. Normal active bowel sounds, no masses palpated, and no hepatosplenomegaly. For GU, there was positive CVA tenderness on the right, and patient reports pain with this maneuver, but she's not in any severe pain. And there were no rashes on the skin that I saw. For ins and outs, the UO has been approximately 0.7 mils per kg per hour since admission. CBC, white blood cell count is 10.44, hemoglobin 11.6, platelet 282. For the BMP, sodium 134, potassium 3.7, chloride 102, CO2 21, BUN 7, creatinine 0.66, and glucose 128. For the UA, the specific gravity was 1.028.
Is that okay? Yeah, the only thing, the white blood cell count is just a little, it's kind of in the range where it's just possibly a bit high. And white blood cell count can be a sign of infection. So it's sort of right at that cutoff for her age. So.
I'm hungry.
I'll be right there.
We're almost done. Sorry.
That was sense of humor.
That's a good sign. She's
Yeah,
hungry.
it is. But for the rest of the UA, negative for blood, negative for nitrate, positive leukoesterase. The squamous epithelium was 21, white blood cell 4, red blood cell 2, and there were many bacteria. And the urine culture, it did grow greater than 100,000 colony factor units of E. coli. And then we also got an X-ray of the abdomen that showed a non-obstructive bowel gas pattern, scattered stool in the ascending colon, and well-formed stool in the rectum, which may relate to constipation.
This is very cute.
So overall, Hannah, she's an 8-year-old female with a recent inadequate treatment of E. coli cystitis and presents with 5 days of lower abdominal pain associated with fever, nausea, vomiting, and diarrhea, now concerning signs for sepsis.
Sepsis, what's that? Is that serious?
So sepsis is a more serious kind of infection. So what we're doing is we're keeping a really close eye on Hannah. Okay, so we're watching her fevers, we're giving her some antibiotics. Okay, and we're just keeping a close eye on her. All right.
And
Okay.
if you want, we'd be happy to come back after too and teach you a little bit more about what we're talking about, because I know
Sure.
some of it's probably hard to understand.
Yeah, it is. Okay, that'd be great.
Yeah. And Hannah, her PCP is Dr. Slade, and she's been notified by a staff message about everything that's been going on. And the last time she saw Dr. Slade was 1 month ago. So for the abdominal pain with the fever, nausea, vomiting, and diarrhea, in terms of my differential, I was thinking possibly pyelonephritis. That's supported by the positive CVA tenderness, the recurrent positive urinary culture for E. coli. She hasn't been able to keep the antibiotics down because of the vomiting, so we might have, it may have started with cystitis and become more complicated with pyelonephritis. We could also consider appendicitis.
Explain later.
Yeah, so a quick summary of that is basically a urinary tract infection can start in the bladder, and it becomes more serious if it affects the kidneys. So that's one of the things that we're considering. So Sana right now is just talking through some of the possibilities, but we're not sure about these yet. So these are what we're going to try and investigate. We'll come back and explain more too.
So just another thing that we're thinking about is possibly appendicitis. That's supported by her positive fever that's been persistent. The exam is showing some guarding, positive pain at McBurney's, and the positive psoas sign. But things that kind of go against the appendicitis would be the negative Rossings. And we could look at the appendicitis protocol, the scoring tool, to kind of assess that further. So I also did some review of literature, and there is a higher incidence of UTI when appendicitis is present, and that's due to the hydronephrosis from the inflammation of the ureter. So just something to keep note of, and less likely would be gastroenteritis. So as for the plan, we can do abdominal ultrasound that'll help us rule out the appendicitis. And we can consult general surgery for that if needed, and continuing the ceftriaxone for the E. coli UTI. So for the E. coli UTI, again, we would do the IV ceftriaxone. We can transition to PO antibiotics depending on the improvement and if she's tolerating the PO. And then for FENGI, there is moderate dehydration. So we can give her 20 mils per kg bolus of normal saline, and then we can calculate her fluid deficit, maintenance, and replacement of fluids. So right now, Dispo's just pending. She's stable currently at Gen Peds, and we're going to monitor her for worsening sepsis.
Good.
Nice.
Any concerns, anything to add from your perspective?
Sounds good.
No? Okay. Anything that we missed or anything that you want to add?
So she's gonna have an ultrasound.
Yep, so the next step will be the ultrasound
Okay.
to try and figure out which of these things that we talked about it could be,
Okay.
or even both. And then we'll go from there.
Okay.
So we'll have the surgeons come talk to her too. And then we'll come back and talk with you later today. Yeah.
Thank you very much.
Thank you.
All right, thanks.